Okay, I think we're right to start. There might be a few more people joining us as the session goes on, but we'll good to get in to the session proper. So this is the PACOP in Practice session for this month, and the topic is communication with families and carers. And I know this is a very big topic. We do run a lot of trainings, in-person workshops, and communities of practice around the PACOP program, and there's overwhelming feedback around the challenges that we face in navigating communication with families and carers, but also navigating expectations and setting our our scope of practice as the clinicians. So we hope to discuss that in the next 45, 50 minutes this afternoon, and how hopefully the PACOP program and the tools that are included can help to support that and help to support the capacity of your team to grow in their palliative care provision. So my name's Simon. I'm one of the improvement facilitators for the PACOP program. I work across Victoria and Tasmania. I also support our other improvement facilitators around Australia. So before we get started, I'd just like to do an acknowledgement of country. I wish to acknowledge the traditional owners of the lands on which we are all living and working, and pay my respects to elders past, present, and emerging. And I'd also like to extend that respect to any First Nations people that are joining us here today for the session. Now, on this screen, we have a QR code, which is if you scan the QR code, you'll be able to receive a certificate of attendance for your CPD for any training. So if you'd like a certificate for this session, please do scan that QR code. If you do miss it, I can come back to it later at the end of the session as well. And I'd just like to let you know that this session will be recorded. So if you don't wish to appear, feel free to keep your camera off. But as I mentioned earlier, it is great to see some of your faces and see your responses to the content there. So we're talking about communication with families and carers. What's currently happening? Where are we seeing the barriers? And potentially, how can we use the PACOP program and the tools to communicate well with our families and have effective and collaborative interactions? So for those of you who've not seen the PACOP program before, I'll give you a quick overview of how the program works, what it looks like, the tools included, and then we'll talk a little bit more about family meetings and how they're structured and how they're evolving. So to start with, um, the PACOP program is divided into two, we call them lanes. The first lane is the profile collection, which is this purple lane. This is when we're looking at our whole community, everyone in our aged care facility, and we're trying to identify using consistent, standardized tools for assessing palliative care needs. So who in our broader community has identifiable palliative care needs? For those residents identified with palliative care needs, they move into the outcomes collection, which is this orange lane. This is where we use the same tools again, but we're using them to answer a different question. We're asking, how effective is our care plan currently in addressing their needs and their changing capacities? And what frequency do we need to be assessing them? So the profile is that screening, that building a baseline for the resident, and the outcomes is looking at these residents with palliative care needs and providing the most appropriate care in that care plan. The way the program works is in the profile collection, we have the actual profile assessment. This is completed on admission. So we're building that profile on admission, that baseline image of our residents on admission, and then doing it once every 3 months. So we're able to then build a bit of a trend and look at the trajectory of this resident and how they're traveling. Unfortunately, our residents don't deteriorate on perfect 3 monthly cycles. So in between those 3 month assessments, we have the deteriorating resident tool, the DRT. This is a condensed version of that profile assessment, and it gives you a very quick yes or no. Is this a palliative change that we've identified that we're concerned about? In the outcomes collection, it's comprised of a daily symptom assessment score. So it's a daily conversation or assessment of our resident looking at their distress. So what's concerning them, bothering them, worrying them. We also have a full full clinical assessment, and this is conducted either weekly or daily, depending on their phase. And we'll talk a little bit more about phases down the track. But one thing I would reiterate is that we're using the same assessment tools, but we're just using them to answer different questions in the profile and in the outcomes as well. And on our next slide, we have a bit of a flow chart, and it is a busy flow chart, but what I'd like to drill down on is the fact that The profile collection and the deteriorating resident tool are both identifying palliative care needs for our resident. When the palliative care need is identified, we look at we move them into the outcomes collection. We put the magnifying glass kind of over that resident. We do a higher frequency assessment just to ensure that the care plan is effective at addressing their needs, but also anticipating their changing needs as their kind of their trajectory progresses. One image that I really like, and I do share it a lot, you've probably seen this image previously, is illness trajectories and how various residents travel on their kind of journey in our facilities. What I'd like you to think about at the start of this presentation is when we're discussing death and dying with families and carers, when we're having these kind of planning meetings, when are they happening? When are they occurring? Are they occurring on admission, or are they occurring much closer to this kind of crisis point where we need to make decisions fast and we need to communicate, readily? Sometimes there's high emotions, there's confusion, and we don't always get the best outcome. So just keep in the back of your mind, when do we see these discussions actually occurring? Ideally, they'd be occurring very early, but what is the reality at the moment? I'll just go quickly over these trajectories as an example. Trajectory 1 is our cancer trajectory. So this is when a resident has potentially a terminal diagnosis. They have a known cancer. We know that their life expectancy is probably less than 6 months, but they seem relatively independent and robust. However, we know that when they do deteriorate, it's likely to happen quite quickly, and we need to anticipate those needs as they occur. Are we having that family meeting at that turning point, or are we having the family meeting when we know that there is a life expectancy of less than 6 months far earlier? With this gold trajectory, it's the organ failure trajectory. This is when our residents, they tend to trick us a little bit. Sometimes they might have a deterioration, they might go to hospital, have some antibiotics, do some rehab, and return to our facility. They've recovered, but they're not always quite back to their baseline. And then they might have another dip, but they'll rally and they'll recover again. And then we get a little bit confused. We don't quite know when that final change is going to occur. So are we having that planning conversation early on that first change, or is it down at this crisis point when we're having those very difficult conversations with families and carers? And then the last trajectory is this dementia and frailty trajectory, the kind of turquoisey green line. Obviously, our resident has had a significant deterioration on their admission. So this is probably something significant's happened in the community. They've come in, they need 24-hour care, but having regular meals, regular medication management, regular daily cares, they've kind of plateaued, and there's no significant change that we can jump on and say, this is the turning point. This is when we're going to start active palliative care. This one's really tricky for families as well, because they might say, well, they're no different to how they were yesterday or the day before. It's when we're doing that assessment on admission, and then every 3 months, we can actually show the journey and show how things are changing as we go along. So you can see this is where we have our profile collection along the top here when we're screening for palliative care needs, and along the bottom, our outcomes collection. This is when we're increasing the frequency and making sure that our care plan is effective at anticipating those needs. Now, the main topics for today. First, 2 questions. What kind of interactions do our teams experience with families and carers? So how do they look? How are they run? Who's there? And how can we build the capacity of our teams to ensure that these interactions are both positive and productive? When we're working with care staff, so RNs, ENs, PCAs, clinical managers, they say that family interactions are often the most challenging, or one of the most challenging parts of the role, navigating their expectations, letting families know what is possible and what you have capacity to deliver, and what is beyond your capacity as well. How do we build that capacity as a whole team? And how can we kind of standardize? Sometimes we have family meetings where we feel like we've shared the appropriate information, but we come away feeling like, I don't think the family was ready to hear that, or I don't think that they took on that information that I was trying to provide. It might not be one meeting, it might be a series of meetings before we get to the best outcome for that resident. So in the back of your mind, I'd like to ask, and potentially if you have So I've just seen a note on the side there. Is everyone able to hear me okay? Wonderful. Sorry, I just double checking. Um, if you have capacity to write a little note in the comments, that would be great. But just think about, okay, family meetings, what format do they take? So who's in the room? Is it the RN? Is it the RN and the GP? Do you have a broader multidisciplinary team that's available? I mean, it's probably rare, but it would be amazing if that was the reality. Some facilities you have a specific palliative care lead nurse that tends to run these family meetings. And my question is, for the broader team, how do they gain that expertise and that exposure and that experience to those conversations if it's not done, as a team? I remember as a junior nurse really relying on mentors to guide me in those conversations and listening in on their family meetings and going, I really like how that sounded. I really like that phrasing. I think I will use that next time. And I think next time I'd like to lead that meeting, that kind of thing. But if those meetings are conducted in isolation, it's very hard for those junior staff or that broader team to really build that confidence around the language. I also like to think about, okay, what kind of families are we working with? Are we navigating? What are the dynamics? What are the challenges? What is the capacity of the family to receive clinical information? What's their health literacy like? Um, are there language barriers? Are there cultural barriers? Um, who's in the room? Is it multiple relatives? Is it one person? How do we adapt to make sure that that communication is functional? And then what is the expectation? What is the expectation from the family? But also, what's the expectation from us as the clinician? What do we want to achieve at the conclusion of this interaction? So, what I'd like to do in the next few slides is look at how the PACOP tools can work as a bit of a scaffold and a bit of a template even for your interactions there. I'd also like to ask, okay, when are these family meetings occurring? Ideally, we have a family meeting prior to admission to establish a relationship and look at that kind of baseline for the resident. Maybe regularly, once a quarter with the family, ideally. When there's a significant deterioration or a significant change, do we have a family meeting? And then maybe when that resident is identified as having palliative care needs, we have a palliative care meeting saying, these are the interventions we'd like to have in place. Is everyone happy with those? Are they appropriate? Do they honor the wishes of this resident? What we would like to do in this meeting, and I'm sure I speak for everyone on this call, is we would like to come to these meetings and convey confidence in our practice, competence that we're assessing and caring for this resident appropriately, and when things change, we'll communicate effectively. Um, and also reassurance. We're reassuring the family that now that this person is in our care, we're able to navigate and support them and their needs, and not only care for that individual, but care for the people around that the family and carers around that person as well. So what I'd like to do is take you through a short case study. It's a very basic case study, but I hope it's one that you can all kind of identify with. It's probably a resident that you've seen before. So we have Roger. He is an 86-year-old gentleman. He's a new admission, previously living in the community with high-level community support package and daily support from son and his daughter. He has increasing frailty, poor appetite, and low motivation to mobilize. He's got a moderate dementia. His needs have been increasing over the last 6 months, leading to recurrent falls and issues with medication adherence. His most recent fall resulted in a fractured neck of femur. He spent some time in hospital on an orthopedic ward and then on a rehab ward, and the discharge planning deemed that he was inappropriate to return home. He's high risk of fall, and there's a significant risk following his cognitive deficits. Roger also has a cardiac history with previous stents, and he suffers from postural hypertension, leading to some syncopal episodes. So a very kind of, hopefully a very readily identifiable resident that you've seen previously. What I'd like to show you are two different families that could be linked to Roger. So the first family you can see here with the brilliance of AI, we have a family, this is family A. They're very concerned and they're needing a lot of information and a lot of reassurance. They're worried that the admission was not the resident's choice and they feel like they've actually let the resident down because they didn't honor their wishes to remain in the community. The decision was kind of made for them, unfortunately. They're insistent on controlling all factors of care, and you can see the people on the left there. They're quite demanding. They're physically quite imposing, which can be quite challenging for those junior staff when they're engaging with these families. This family is really focusing on diet and rehab because this is what they were talking about when they were in the hospital. They were talking about physio, they were talking about rehab, they were talking about building capacity, building capacity. This family's got a really good health literacy and they're persistent advocates. This is the kind of family that's on the phone every day, wanting updates and challenging our interventions. I've written their squeaky wheel. It's not a term that we use kind of professionally, but the squeaky wheel gets the oil. This is the family that is really good at advocating for their resident, and they're kind of a high priority family. On the other side, on the other hand, we have family B. Now, this family is a little bit more, I guess, surprised. They're shocked at the recent change in the capacity of their loved one. They're not yet willing to engage in this kind of end of life discussion and planning. They haven't nominated a medical decision maker. They're very keen for the resident to return to their previous baseline prior to hospitalization, and they maybe have a poorer health literacy. So they don't have a very comprehensive understanding of exactly what's going on and what to expect next. So we're coming into these family meetings. First of all, we have to figure out what are the needs of the family? What's the best way to communicate with this family? And how are we going to have an effective interaction that is positive and that we can continue going forward as we have more family meetings as well. So what are we doing on that initial family meeting? We're building a baseline using the profile collection. So using that PACOP assessment, we're trying to build a really good picture of the needs of this resident. We're using a structured format for this family meeting. So we're telling the family on admission, this is what you can expect when we catch up with you. There's a number of topics we'd like to touch on. We need to build rapport with this family. And as you can see, my wonderful AI nurse has now turned into a detective, a bit of a Sherlock Holmes. She's not only looking at the resident, we're so good at assessing our residents, but now she's assessing the family. What is their capacity? What is the best mode of communicating with this family? What is their understanding of what's going on? How much do they know about this situation? And what other barriers are we seeing? And I think a lot of us in these meetings, we do this very naturally and organically because we're nurses and that's what we do. We walk into a room and we assess and we see, where the gaps are. We're good at doing it with our residents. Can we do it with these families as well? This is also we're outlining our role as a clinician and the roles of our broader team. So that from the outset, we can say, sorry, there's just something keeps popping up here. Okay, sorry. We're saying this is the role of our team. This is what you can expect that we're able to provide, and this is probably the limitations of what we can deliver. But we're also asking, what does the resident want? And we can ask this of the family. We're saying what is in the best interest of the resident, and they can be included in this initial interaction as well. What matters most? What are we hoping for? Would it help if we talked about what's ahead, what we anticipate happening, and what is your understanding of this illness? And one kind of model we use a lot, which is shared often, is that ask, tell, ask model, where we say, okay, what are you seeing? What is your understanding of what's going on? We, as the carer, have done these assessments on admission. This is what we're seeing. What are you seeing? Okay, can we supplement that information with the assessments that we've completed? And then we ask again, okay, what are you seeing? What do you think is the priority? And what do you anticipate going forward? And it's a really good way of gauging where the family and the carer are at and what their expectations are. We're using the same information, but again, we're looking at two very distinct families, family A and family B. So let's have a look at how we might navigate that with the families. But first of all, we'll look at the actual profile collection. So some of you may already be implementing the PACOP program in your facility. Some of you might be thinking about implementing. We'll have a quick look at the profile, the assessments that are involved, and how we can kind of harness that information there. So the profile collection, this is on the screen now is the face-to-face assessment. This is our part A of the profile. It utilizes five very distinct tools, and they're all robust on their own. But when we put them all together, we get a great kind of comprehensive understanding of really what is happening with this resident. It's very clinical. So when we're speaking with our families, depending on their capacity and their, the best mode for communicating, we can adjust the language to still reflect the same information. So our first assessment in the top left of the face-to-face assessment is the PACOP symptom assessment score. And the key word with this assessment is distress. So when we're speaking to the families, we can say, every time we catch up for a formal family meeting, we are going to talk about distress. What are we identifying? What is the resident communicating to us that is worrying them, concerning them, bothering them? How do we prioritize what's happening today? The next assessment is the problem severity score, which sounds very clinical, but problem severity, we're basically saying, what are the main problems we're seeing today? How quickly do we need to act on them? Is this something that we need to resolve immediately, or is this something that we can kind of watch and wait, make sure that the care plan is effective and kind of keep an eye on? And that's a really nice way to communicate with families. We can say, this is what we're seeing as the biggest problems today. Do you agree with that? What are you seeing as the main problems? How do we prioritize that? The next assessment is the Australian Modified Karnofsky Performance Status. The way I teach it is that the key word with this assessment is capacity. So what is the capacity of the resident to, to perform ADLs, to do their activities and work? We say, what is their capacity on admission? What is their capacity every 3 months? And how quickly is that capacity changing? Then we can look forward and say, okay, if that capacity is changing month to month, what do we anticipate in the next few months? If it's changing week to week, what do we anticipate in the next few weeks? The same day to day, what do we anticipate in the next few days? The fourth tool is the resource utilization group's activities of daily living. We call it the RUG ADL, but the key term there is resource. What are the resource demands for this resident? So for us to provide the best care for this resident, how many people are in the room and what equipment is required? What was it on admission? What is it today? What do we anticipate it will be going forward? So we're kind of, I guess in a way, we're trying to relieve the decision-making burden from the family. We're trying to share the information with them and say, this is what we're seeing. This is how we'd like to anticipate the needs and, adjust the care plan appropriately. Does that sound okay? Is that effective? Is there anything you'd like to add? So we're not asking the family to be kind of quite determine what the care is. We're saying, here's a framework, here's some tools, here's some language. What are you seeing and how can we collaborate together? The number 5 of those tools that we're looking at is our Rockwood Clinical Frailty Score. And this is a very unique assessment. It's specific to people over the age of 65. So it's assessing frailty, both physical and cognitive, our key demographic in residential aged care. The nice thing is that we're looking at frailty, both physical, but also cognitive. So when there's a mild, moderate, or severe dementia, we can also link that with risks for deterioration as well in that frailty picture. And we're actually providing, whether the family has really good understanding of what's going on, or whether they're very new to this kind of health language, talking about frailty and the risk of change is quite accessible, I hope. We also have, at the bottom of that page, communication. So how often are we able to communicate with the resident? Are they able to provide feedback? How often are we able to get feedback from the family and carer? And also, how often is the resident being visited by the family or carer? We all know what isolation can do as a key indicator of deterioration and change. So it's invaluable information to capture on a regular basis. If we turn over to the following page, we look at reasons for care. And this is really helpful, I believe, for those families that are not 100% aware of the complexity or everything that's going on for this individual's kind of illness pathway. So we're asking, what's the main reason for care? So for Roger, potentially his mobility has changed, his increasing dementia, his cardiac history. he's come in with this advancing frailty, but he's got all these other components to his care that are compounding and making his overall illness trajectory far more complex. So it's a nice way of highlighting, yes, the main reason for care for Roger is his advancing frailty or his advancing dementia, but we're also providing all these other elements. And when that changes, maybe the main reason for care in the future might be severe dementia, or it might be active palliative care. But the family is already aware of this language, so we can evidence how things are changing. Below that, we have questions around planning. I think when we say palliative with families, immediately palliative is kind of colored in by their experiences, what they've seen, what's happened to their family, what's happened to their friends, stories they've heard. But when we talk about palliative, we're talking about anticipating needs, supportive care, comfort measures. We're not actually talking about death and dying in the immediate. We're talking about what would you like to happen? What are your preferences? What is important for you? So when it comes to this planning question, we're talking about, okay, do we have an advanced care directive or an advanced care plan? Is it appropriate? Do we have a nominated decision maker? Not for today, but for when things change. Let's build that kind of capacity. And then over the page on our action plan, we're actually saying, now that we've discussed where we are today and what we anticipate will happen going forward, what is an appropriate action? Every time there's a change, would we like to organize another family meeting? Would we like to involve the GP? Do we need to update the advanced care plan? All these things. Looking at a family member face on can be extremely intimidating and a little bit overwhelming. But sitting alongside a family member, looking at the same information in front of you, can be very collaborative and very positive, and it actually deflects that resistance, I think. So having this tangible information as a basis for informed decision making can be really, really beneficial. I'm going relatively quickly, so I hope you don't mind that I'm going through a lot of the the tools quite quickly. But please, if you let me just have a quick look. Oh, wonderful! Thanks for your feedback in the chat there, just in terms of who's involved in the family meetings. That's great. So what we'll do now, we've done a profile assessment on Roger, and we've communicated with this family, and we've set up kind of this baseline saying once every 3 months, we're going to do the same assessments. We're going to look at distress, problem severity, capacity, resources, frailty, and communication. And so the family is kind of aware of what to expect with these interactions, and the burden is not on them to, you know, take on all this information and make an informed decision on the spot. So let's go back and have a little look at Roger and how he's traveling a few weeks later. So our update for Roger, he's had continued weight loss. He's reduced his oral intake. He has a limited appetite, increasing confusion and disengagement from activities. He's reluctant to mobilize due to pain. Now, this pain may be second to his fractured noth and the procedure prior to admission. It might be a new pain, but it's definitely an increased symptom. He's also complaining of breathlessness, and we've noticed it as clinicians, but the resident has also let us know that he's feeling quite breathless. So this is a new symptom as well. We're going to grab our deteriorating resident tool, which is whenever we have a resident of concern, a resident with changed symptoms, changed cognition, increased or new symptoms, increased falls, anything that you're worried about, anything that your quality indicators are pointing to, that deteriorating resident tool will give you a very quick yes or no. This is a palliative change. This person could benefit from palliative care. So let's look at this deteriorating resident tool. Again, we use the distress scale from the point of view of the resident, ideally, but it also says if the resident is unable to rate their symptom assessment, we also have the family or carer, then the care worker who's in the room with the resident every day, who knows the resident probably best in the facility, and then lastly, the healthcare professional. So we're looking at the distress level of this resident. And again, distress is a very clinical term. We can say worry, concern, what's bothering them, anything like that. We're looking at distress. We're looking at the problem severity. What is the main problem we're seeing as the carer today? And can we triage it, mild, moderate, or severe? And has it changed from that baseline assessment? The Karnofsky performance scale, we're looking at that capacity question once again. Potentially Roger on admission, he came in as a 50, requires considerable assistance and frequent medical care. He may have dropped down to 40, so he was in bed or chair more than 50% of the time. Now, when we're doing our deteriorating resident tool, he's got increased pain, he's got breathlessness, and his mobility has definitely decreased. We could even say, yes, Roger is scoring a 30 on the AKPS on that capacity question. So he's gone from 50 to 40 to 30 in a matter of weeks. We can kind of project, okay, well, how quickly are things going to change in the weeks going forward as well. Over the page on that second page of the DRT, we have the frailty question. Roger's frailty was moderate dementia, so he was moderately frail, but now we're seeing that he's increasing confusion. He's now completely dependent for personal care, making him severely frail. So we've seen a change in there as well. So already within 2 assessments, we can show a trend and a change that is quite accessible, even without that clinical insight. The questions at the bottom of the DRT point towards, yes, this is a palliative change for this resident. So he has distress and problem severity scores that are moderate or severe for pain and breathlessness. He has a changing AKPS that is less than 40. And based on our clinical judgment, we think that he could definitely benefit from palliative care. So we've already got 3 yeses to move Roger into the outcomes collection. But when we come to communicating with his family, we're taking that clinical information and we're trying to break it down in a way that is most accessible and most appropriate for each of those families. Okay, so we'll jump across. So family A, this is the family that was very focused on the things that they could control. So things like diet, mobility, rehab. This family may really benefit from a discussion around the SAS distress score. And we've seen this done quite a lot in our facilities that have been implementing PACOP for a while, 6, 12, 18 months. When there's a family that is concerned or worried, they will actually take the DRT to the family meeting and do the assessment with the family and ask them what are they seeing. So for this family that's really focused on oral intake, weight loss, rehabilitation, when we go back and we say, okay, from Roger's point of view, what do you think are his biggest concerns today? I don't know that he's voicing that he's worried about his appetite or worried about his mobility. The things that he's telling us are that he's worried about pain and breathlessness. And those are the things that we'd really like to drill down on, the needs of the resident from their point of view, and what is the priority for today. So this is a nice way of kind of reframing information for that family to say, we understand that you're worried about oral intake and weight loss and rehab, but at the moment, the things we're seeing are pain and breathlessness. And that's what we'd like to kind of focus on and make sure that the care plan is providing comfort and security for Roger as well. With Roger's advancing dementia, we also have an increase in rapid deterioration. So we can also use the Rockwood Clinical Frailty Scale to say, actually, his overall frailty score is changing. And that means he's at much higher risk of deterioration and his needs may be changing. So from admission to today, we've seen a change. What do we anticipate will happen in the next few weeks or months? Can we prepare kind of proactively for that eventuality as well? For family B, they're still confused. They want to know, why has this change occurred? Why has he continued to be more confused? Why is he not mobilizing? They may actually benefit from a different assessment in terms of their understanding. So you can actually use the AKPS score. The AKPS score, that capacity question, it uses language that is not overly clinical. As we said, we can say, the family might say, well, if he's deteriorating, how much time do we have left? Now, we can't actually say you have exactly 4 weeks or 3 months, something like that. But we can say his capacity has changed in a matter of weeks, and let's project that forward for a number of weeks. This is what we anticipate will happen next. So if he's scoring a 30 now, almost completely bedfast, we anticipate that the next thing we'll identify is that he's totally bedfast, requiring nursing care by professionals. And when that happens, we would like to adjust the care plan to make sure it's appropriate as well. Does that sound appropriate? Is there anything you'd like to add from the family? Things like that. So you can see how the same assessment can be used to provide confidence, project competence, and also reassure the families that we are aware of what's going on and what we're planning appropriately. All right. So we'll jump forward. So for Roger, we've identified that yes, he has a palliative care need. We've moved him into the outcomes collection. This means we're going to be doing a full clinical assessment, either daily or weekly. The outcomes collection is this orange assessment form. It's a one sheet, but again, although it looks different, we've got our distress score, the SAS distress score. We've got the problem severity score. What are we seeing as the main problems today? We've got our AKPS capacity question and how is it changing? And we've got our RUG ADL resource question. So how many people and what equipment is required to best care for this resident as well? This assessment has a number of days, so we can actually build a trend over a number of days to see whether things are improving or things are deteriorating as well. So we can communicate this with the families. And if we've been using that consistent language on admission and then for our regular family meetings, by the time we get to this outcomes phase, the family is aware that yes, we're going to talk about distress. Yes, we're going to talk about problem severity. Yes, we're going to talk about capacity. And yes, we're going to talk about resources. And they have a bit more of a framework to receive that information as well. Now we do this assessment to allocate a phase. The phases are stable, unstable, deteriorating, or terminal. And they are really specific to our care plan. How effective is our care plan? How regularly should we be assessing? And how appropriate and responsive are our interventions as well. For everybody that moves into outcomes with the broader PACOP program, everyone that's in outcomes, so everyone with an identified palliative care need will have a daily SAS. And that's a daily conversation with the resident or with the resident's families and carers around distress. What are we seeing today that is causing the most concern, the most worry? What is bothering them? This is a conversation that can be conducted by our care staff, by our RNs, by our ENs, but it also allows for this consistent dialogue with families as well. So we're saying, what are you seeing? What are you noticing is the most concerning or the most distressing thing for this resident? What do we need to prioritize going forward? And it means that the family feel included. They're not on the outside, they're actually part of that caring process. And it means that their voice is being heard. So there's less chance of complaints or disagreements if we're having this consistent conversation around the resident, the person who's at the very center of everything. Okay. So that's the daily SAS. So everyone in outcomes will have a full clinical assessment, either daily or weekly. They'll also have a daily SAS, or daily conversation around distress. So we'll go back to our family. We've got family A and family B. We're using this consistent language that is kind of throughout the PACOP program. We're using it in our updates and our family meetings. So not only just our formalized family meetings, but potentially phone calls, discussions we have in the corridor with family. We're using these consistent metrics. So it doesn't matter who's on that shift or who's available to communicate. We're using this consistent language around distress, problem severity, capacity, resource. And we're putting it in a way that relieves the decision-making burden on the family. We're providing that information, and some of our more experienced clinicians can definitely do this really well, where they say, this is what I'm seeing, this is what you're seeing, this is what we'd like to do, and this is what I would recommend in this situation. And then anticipating the needs going forward, this is what we'd like to get ready for. So it's building that overall confidence in the team and also in the family and the resident as well, so that we avoid this kind of crisis point where decisions need to be made in haste, where there's high emotions. Sometimes we end up with unnecessary hospitalizations, all those benefits of early and comprehensive communication as well. So that's kind of the end of our case study for Roger. I just thought we'd kind of take Roger through the profile, the DRT, and then outcomes as well. All the assessments that we've referenced today are available on the PACOP website, so you're welcome to go onto our website and have a look. There's also our education materials on the website as well. If you have any questions, you're welcome to contact myself or the PACOP inquiries line, and I'll show you those links in just a moment. But before we finish up, I'd like to just show you some of the things that are available as part of the PACOP program as well. So for those facilities that are implementing the PACOP assessments, we run communities of practice, which is a monthly virtual session where we talk about barriers to implementation, things we're experiencing, profiling our residents, communicating with families and carers, um, recent deaths that have occurred, so significant deaths, good deaths, bad deaths, room for improvement, lessons learned, that kind of thing. The initial communities of practice tend to be around navigating implementation, but as the sites mature, we talk more about these significant deaths and experiences, and facilities can kind of learn from each other because we're all working within this one industry and we're all seeing the same challenges as well. So it's great to see this kind of collaborative approach to delivering best care. We have a number of our resources on our website, and these include pamphlets and information for families, carers, GPs. And we also have a number of these tools and brochures translated into various languages depending on your specific population. We have our training modules. So within our training platform, which is also on our website, we have an introduction to PACOP portal, which is a short kind of intro to the overall program. It's really good for GPs and executives at your facilities. We have the PACOP fundamentals assessments, PACOP fundamentals education, which is for RNs and ENs that are learning the whole suite of tools. And then we have the Peacock SAS tools, modules for care staff as well. So that really opens up that palliative approach to not only your RNs and ENs, but also your care staff and those that are really passionate about palliative care as well. And we also have our YouTube channel. We're very proud of our YouTube channel. It's got some amazing videos on there, in particular the clinical bites. These are short versions of each of the tools. So little education snippets of each of the tools. So great when we're rolling out PACOP and kind of helping our teams to learn these tools and implement them one by one. And that is the end of my presentation.